I'm your today's host for this BCPS preparatory classes. I welcome you all back in our lecture series, and I wish you and really hope that you people are getting best of benefit from these classes. So as we are also going towards the end of our program, so we really wish and hope that on behalf of Going Back to Pharmacy in Pakistan, that you people are taking full benefit from these lectures, and also that your active participation and your consistency in these classes are making this program really very successful. So moving towards our today's topic, that is related to oncology supportive care. We have our respectable faculty member, Dr. Mansoor Ahmed Khan, with us today. I would like to give a brief introduction of Dr. Mansoor with you people. That Dr. Mansoor is currently working as a senior clinical pharmacist covering oncology, hematology, BMT at Ministry of National Guard Health Affairs, Jeddah, for the last 13 years. He had obtained his American BPS certification in oncology, BCOP, in 2010 and recertification in 2017. He is a keen member of important committees in the hospital, including PNT committee, and his formulary management recommendations have significant cost-effective impact in Ministry of National Guard Health Affairs. He is heavily involved in teaching students, residents, and fellows in the hospital as well as in the university. He has also been involved in the research. He established clinical pharmacy services in Princess Noura Oncology Center and other services and department. I welcome Dr. Mansoor in our today's class. Aslan sir, how are you?
Thanks, Dr. Rita, for your excellent introduction. And I would like to say, first of all, Assalamu alaikum to everyone. And thanks, Rita, for excellent introduction. And I would like to appreciate and acknowledge the efforts of Dr. Rana Kamran and the whole group, and Giving Back to Pharmacy in Pakistan and all the volunteers for putting great efforts. Actually, I had been dreaming since we started Giving Back to Pharmacy Pakistan platform a couple of years ago, that we really need to do this kind of exercise. We really need to take this initiative in order to enable our countrymen have this board certification. And board certification definitely equips you with a lot of education and training, and of course clinical skills, which helps you to become a good professional. So it's really like a dream come true, and I would like to once again thank Dr. Rana Kamran and his team for this initiative. So can you please allow me to share my screen?
Yes, sir. You may share your screen.
Okay. Can you see my screen now?
Yes, sir.
Okay. Okay. So those who are working in oncology, hematology, they know that oncology, hematology is one of the fastest and one of the biggest growing discipline in terms of drug development activity. Over the past 5 years, more than 250 drugs and indications were approved by US FDA, which is really unmatchable when you compare it with other disciplines. So around 40 to 45% of the drugs and indications which are approved by US FDA, they belong to the domain of oncology and hematology. And the rest of the 55, 60% belongs to non-oncology domain. And most of the medications and indications which were approved belong to the target therapy and immunotherapy. And of course, development of these innovative molecules comes at the significant cost of physical toxicities as well as the financial toxicities. So in that perspective, it's the responsibility, utmost responsibility of the oncology pharmacist, clinical pharmacists to provide ample amount of supportive care to our oncology patients in order to make them, compliant with the treatment, they tolerate the treatment, which definitely improves the overall outcomes of treatment. So the purpose of this talk, which we are going to present today over the 1 hour and a half, is basically to orient you with the BCPS sort of questions which can be asked in the BCPS exam, BCPS certification exam. Well, oncology supportive care is an immense topic. I need months, if not days, definitely not hours, to encompass the whole topic. But we'll try to discuss most important relevant topics for the BPS certification exam. I don't have any disclosures related to the contents of my presentation. And these are my objectives. I think I have already mentioned my objectives. So we'll talk about the most relevant topics of oncology supportive care, which is relevant to the BPS certification exam, particularly chemotherapy-induced nausea, vomiting, growth factor support, bone marrow suppression. Lots of patients, they have anemia and fatigue. There are conventional chemotherapies, as anthracycline can cause cardiotoxicity. We'll talk about some of the antidotes for ifosfamide, for doxorubicin, anthracycline. We'll talk about cancer-related pain and cancer pain syndromes. And lastly, we'll talk about some oncology emergencies as febrile neutropenia and tumor lysis syndrome. So let's begin with chemotherapy-induced nausea and vomiting. So these are the resources if you would like to cover this topic and read this topic very well if you are an oncology practitioner. So NCCN guidelines is the most comprehensive guidelines. These guidelines are updated 2 to 3 times in a year, and they provide you the most recent updates. We have ASCO guidelines and MASC guidelines as well. So let's begin with this topic, with this question, first audience response question. So we have a 55-year-old woman, F5, who was recently given a diagnosis of relapsed Hodgkin disease. So she will begin treatment with cisplatin, 100 milligram per meter square on day 1, plus gemcitabine, 1000 milligram per meter square on day 1, and then it will be repeated on day 8. And then dexamethasone, 40 milligram for 4 days, and the cycle is repeated every 21 days. So what do you think, which is the most appropriate antiemetic regimen for preventing acute hemolysis? Is it A, aprepitant plus olanzapine plus dexamethasone, or B, aprepitant plus granisetron plus dexamethasone, or C, or D? I think I forgot to coordinate with Rita that if we have any polls, if there are any mechanism that we can assess the audience, the next time I think we can consider that. So we'll come back to, do we have any polls, any mechanism to assess the audience?
I'm sorry, sir, not right now, but our participants may respond in the chat box, or they may also respond verbally.
Perfect.
So participants, you are very welcome to give options in the chat box, please.
So, one of the participants, Dr. Bushra Anjam, she has answered C, and she is right. She is 100% right, and I'll explain why it is C. My slides are not moving. Okay. Okay. So first, let's try to understand the chemotherapy-induced nausea and vomiting. Chemotherapy-induced nausea and vomiting is one of the complications, very worrisome complication. Most patients, when they think about cancer disease or cancer patient, the first thing that they think about is the cancer-induced nausea and vomiting. What I have seen in my career in 1990s, late 1990s, that many patients, they had been throwing their gut out in Pakistan, where the cutting-edge antiemetics were not available. I'm not talking about Shaukat Khanam Cancer Hospital, where I had been practicing in other hospitals. So the people had been throwing their gut out, and before the era of the 5-HT3 receptor antagonist and substance P antagonist, people had been really refusing chemotherapy for even curable diseases such as lymphoma and leukemia because simply they cannot tolerate the chemotherapy-induced nausea and vomiting. And if you're not able to control the chemotherapy-induced nausea and vomiting, definitely the patient will not be compliant with the treatment, and they will not be able to give the 100% dose. They will not be able to maintain the dose density and the dose intensity, and that affect the overall outcome in cancer patients. So we had seen significant progress over the past 20, 25 years. We have many 5-HT receptor antagonists like ondansetron, like granisetron, palonosetron, etc. We have many neurokinin 1 receptor antagonists or substance P antagonists, such as aprepitant. We have netropitant, rolapitant, long-acting one. But despite this, I'll show you a study where people are still suffering from chemotherapy-induced nausea and vomiting. Particularly delayed nausea is really affecting the quality of life of these patients. There are many guidelines that you can go through, like NCCN guidelines, ASCO guidelines, and MAS guidelines. But these guidelines do not address all the scenarios. So typically they talk about day one chemotherapy. For example, you are giving a chemotherapy today, so they'll talk about acute chemotherapy-induced nausea vomiting, which means to prevent it on that particular day. And the delayed chemotherapy-induced nausea vomiting will be the day after and 2 days after. Whereas in real situation, you see multiple days chemotherapy, you see the conditioning therapy for the stem cell transplants, you see oral chemotherapy, which is given on a daily basis. So these kind of scenarios are not covered by international guidelines. So that's why it's really complex when you are providing the care to the patient. So let's try to understand the pathophysiology of the chemotherapy-induced nausea and vomiting. And if you can see, there is 2 different mechanisms. There is peripheral mechanism and there is central mechanism. The peripheral mechanism, the chemotherapy can cause the release of the free radicals, which can stimulate the antipermeatin cells of the GI tract. Then they bind with the 5-HT3 receptors in the efferent vagus nerve fibers, and that take the impulse all the way to the chemoreceptor trigger zone or nucleus of tract solitarius, and that initiate the vomiting action. And other ways, it's the central mechanism where the 5-HT3 receptor antagonists or NK1 receptors NK1 receptors are stimulated. 5-HT3 and NK1 are released, and then they bind with the 5-HT3 and the NK1 receptors, and then they initiate the vomiting action. So there is another thing that I would like to explain: acute nausea vomiting versus delayed nausea vomiting. There are different mechanisms involved for acute versus the delayed. For acute nausea vomiting, the mainly 5-HT3 receptor signaling is involved for acute chemotherapy-induced nausea vomiting. And this mechanism we have to apply in our clinical practice as well. And that's the reason 5-HT3 receptor antagonists, such as granisetron, palonosetron, these are mainly used for prevention of acute chemotherapy-induced nausea and vomiting. They have very minimal role in prevention of the delayed chemotherapy-induced nausea and vomiting. Whereas the for delayed chemotherapy-induced nausea vomiting, the main signaling pathway is actually NK1 signaling pathway, and that's why aprepitant, netropitant, and rolapitant, they are effective for delayed chemotherapy-induced nausea and vomiting. They're also effective for acute as well as delayed nausea and vomiting. So these are the definitions. Nausea is the inclination to vomit, a feeling in the throat or epigastric region, but it's actually not the vomiting action, but it's inclination to vomit. And that affects the quality of life of patient. And vomiting is the actual ejection or expulsion of the gastric content through the mouth. So both nausea and vomiting, they really affect the quality of life of these cancer patients. These are some of the important definitions to understand. Acute nausea or acute emesis is the vomiting or nausea which happens on the day of chemotherapy, within 24 hours of receiving chemotherapy. Whereas delayed nausea vomiting is defined as nausea or vomiting which is occurring within after 24 hours of receiving chemotherapy. And that may continue for 5 days, and in case of cisplatin, it may continue even for longer than 5 days. But typically, most of the guidelines and most of the scenarios, they try to cover up to 3 days after chemotherapy, 2 to 3 days after chemotherapy. Sometimes we see patients, those who have like uh, bad experience from the first cycle of chemotherapy, and they had nausea and vomiting, and the objects that they look at and the thing that they smell and the voices that they hear uh, in the second cycle, that they may trigger the action of vomiting even before the start of chemotherapy, and that's called uh, anticipatory emesis or anticipatory vomiting. So this is a reflex action, and we have to understand this mechanism, and for that reason, we have to get benzodiazepine, particularly lorazepam, in order to have some sort of amnesia, so that the patient forget the previous experience, as well as some people have anxiety-related diarrhea, sorry, anxiety-related vomiting. So lorazepam can counteract that, can prevent that. Then we have breakthrough vomiting. So breakthrough vomiting or nausea, it may happen when you give standard anti-emetic prophylaxis based on international guidelines or your institutional guidelines, and the nausea vomiting still happens. It's called breakthrough vomiting or breakthrough emesis or breakthrough nausea. Nausea is something which is quite underrated, not very well reported by patients, by healthcare providers in the literature as well. But this is one of the things which most significantly affecting the quality of life of patients. So in that case, you have to use another different antiemetic from the different class in order to treat the breakthrough emesis or breakthrough vomiting or breakthrough nausea. And the last class, last definition of vomiting or emesis is refractory. Refractory emesis is the one which does not respond to any antiemetic. So despite the fact you're giving standard antiemetic prophylaxis, you're giving breakthrough doses of antiemetic, but still nausea vomiting is happening. So that's called refractory emesis or vomiting. So these are some of the risk factors. This can be asked in the exam. I'm not sure about BCPS, but these can be asked in BCOP. So the younger patient, like patient age less than 40, female gender, history of motion sickness, and those women who had nausea vomiting history during their pregnancies, poor control of nausea vomiting in previous chemotherapy cycles. All these are the risk factors, and those people who have depression and anxiety. So that's why I was talking about lorazepam. And the people need to sleep very well the night before the chemotherapy. That's another risk factor. If they do not have enough sleep, so they can have nausea vomiting. And alcoholism is not a good habit, but it's quite common in Western society. So those who have chronic alcoholic, they kind of have less incidence of vomiting. So it's kind of protective. I'm not promoting the idea of alcoholism, but it is protective. So now move to the classification. There are 4 different classes in NCCN, ASCO, and MASC guidelines. If you do not give antiemetics and patients have nausea vomiting in more than 9 out of 10 or more than 90 out of 100 patients, that's called highly emetogenic chemotherapy. If that happens in 30 to 90% of patients, 3 to 9 out of 10 patients without the provision of the antiemetic prophylaxis, that's called moderate emetogenic chemotherapy. The low is the one which has 10 to 30% and less than 10% is called minimal emetogenic chemotherapy. Okay, we discussed the risk factors. So this is NCCN guidelines. I would like to make you familiar with the NCCN guideline, which is National Comprehensive Cancer Network Guidelines of the United States, the most reputable guidelines used globally. So they categorize patients into these 4 classes, which I have just mentioned. And I can take you here, like in the question, there is cisplatin. The patient is receiving cisplatin, so it's highly emetogenic chemotherapy. And there are other combinations like AC, cyclophosphamide, and doxorubicin combination, carboplatin, AUC more than 4 equal to 4, and cyclophosphamide dose of more than 1.5 gram per meter square, which is used in the transplant setting. These are all highly emetogenic chemotherapy. And most of the questions which can be asked in the exam, whether BPS or BCOP, are related to highly emetogenic chemotherapy. So that's why your focus should be here. And then we have moderate, so you can go through my slides. You can ask Rita, she can provide you my slides. Then you can go through the slides, and even you can go through the NCCN guidelines. It does not need any fee for the subscription. It's a free subscription, so you can download NCCN guidelines and go through them. And then we have low emetic risk and minimal emetic risk. And then we have oral agents, which are classified into, categorized into two classes: moderate to high emetic risk, minimal to low emetic risk. So this is the algorithm. There are three different options in NCCN guidelines for prevention of chemotherapy-induced nausea and vomiting. The option A is preferred. So whenever you are preparing for board certification, you have to look at the guidelines, NCCN guidelines for oncology, hematology, and then you see like which recommendation is preferred or which recommendation is category 1 recommended treatment options. So most of the time, the examiner is trying to ask a question which is preferred regimen or which is category 1 recommended treatment options. Okay. So a preferred option is A, which includes four different groups of antiemetics. So you have to choose one of the NK1 receptor antagonists, which could be aprepitant IV or oral, which could be netropitant IV or oral in combination with polonosetron or rolapitant. So you have to choose one of them from NK1 receptor antagonist. Then you have to choose one from 5-HT3 receptor antagonist, which could be dolasetron, glinisetron, ondansetron, polonosetron. And the fourth drug is dexamethasone. So this is for acute, day one. You can look at my arrow, it's day one. Day one means day one of chemotherapy. That means acute chemotherapy-induced nausea, vomiting prevention regimen, okay? And for the day 2, 3, and 4, this is delayed chemotherapy-induced nausea and vomiting. Sorry, I beg your pardon. I did not mention olanzapine. So fourth drug is olanzapine. Should be somewhere here. Yes, the top of the list is olanzapine. So actually, there was a recent study published like 3-4 years ago, which included olanzapine to 3-drug combination and had proven the fact that when you add olanzapine to 3-drug combination, it improves delayed chemotherapy-induced nausea, particularly delayed nausea, significantly. And that's why American Society of Clinical Oncology, MASC, and NCCN, they have included olanzapine as a 4-drug combination. And this is now preferred regimen. So this is for the day 1, you have to choose 4 drugs. And for the day 2, 3, and 4, you have to use olanzapine and you have to use dexamethasone. And if you are using aprepitant on day 1, 125 milligram, then you have to use 80 milligram on day 2 and day 3. And if you're using netropitant or phosnetropitant or IV aprepitant, then you don't have to use anything on day 2 and day 3 of NK1 receptor antagonist. And another thing that I would like to point out, this is this can be asked in the exam question as well as for your clinical practice. When I joined my hospital here, people had been misusing a 5-HT3 receptor antagonist a lot. So I brought out this evidence to the prescribers, to the people, stakeholders, and we removed the 5-HT3 receptor antagonist from the delayed chemotherapy-induced nausea, vomiting prevention, because people used to prescribe it for 2 weeks, 3 weeks after chemotherapy. And by doing that, we were able to save a significant amount of money, not only the money, but also the drug-drug interaction and toxicities from these 5-HT3 receptor antagonists. So there is no room for 5-HT3 receptor antagonist for delayed chemotherapy-induced nausea and vomiting, as you can see in the NCCN guideline. Option B is non-NK1 receptor antagonist. So you can use olanzapine, polonosetron, and dexamethasone. Is not a preferred regimen. And then option C can still be asked in the exam question, and that's what I asked you in the previous audience response question. So it's basically a 3-drug combination. It's without olanzapine. It's category 2A recommendation. Any recommendation which is not mentioned is category 2A. And another thing that you have to focus is the interaction of aprepitant or netropitant with steroids. They are CYP3A4 inhibitors, so they reduces the metabolism of dexamethasone. So in that case, you have to reduce the dose of dexamethasone from 20 to 12 milligrams. Okay, so this is the algorithm for the moderate hematic risk. So in moderate hematic risk, you have three options again. So basically, you choose two drug combination, like 5-HT2 receptor antagonist and dexamethasone. You don't have to use NK1 receptor antagonist for all. Or you can use three drug combination, adding olanzapine, palonosetron, dexamethasone, which is quite commonly used now these days. And then those people who have like nausea, vomiting, despite using 2 or 3 drug combination, you can add NK1 receptor antagonist. But most commonly, people are not going to ask you question for moderate, minimal, or low risk immunogenic chemotherapy. They're going to ask you question about the highly immunogenic. So we are coming back to the question, audience response question number 1. So the answer is B. Sorry, somebody was writing C before. It cannot be C because aprepitant is NK1 receptor antagonist. That's right. Then we have granisetron, which is 5-HT3 receptor antagonist, and then palonosetron 5-HT3 receptor antagonist. You cannot have two 5-HT3 receptor antagonists. You should have one NK1, one 5-HT3 receptor antagonist, and dexamethasone. And if there is olanzapine option there, then I would suggest you to go for olanzapine option. Okay. So B is the correct answer. B is the correct answer, not the C, because in C you have two 5-HT3 receptor antagonists. Okay. So the next audience response question is about anticipatory nausea and vomiting. We have 4 options: aprepitant plus olanzapine plus dexamethasone, and aprepitant plus granisetron plus dexamethasone. We have netipitant plus palonosetron plus dexamethasone plus lorazepam, and lorazepam, rolapitant, and metoclopramide. So what do you think? Which option is correct? Okay. Dr. Noreen is saying my answer was B. So the correct option here is C, correct. Because for lorazepam, you have to add for anticipatory nausea vomiting. So the benzodiazepine, I think I talked about it because of paucity of time. I need to go over quickly. It reduces not only anxiety, but also it causes sort of amnesia and prevent the previous, it makes the patient forget the previous experience of nausea and vomiting in the previous cycle. And sometimes we use metoclopramide or haloperidol and phenothiazine, which can cause sort of EPS, and it can also treat the EPS. So it's quite helpful. So the option C is correct answer. So this is just a summary of the ESCO, NCCN, and MAS guideline for highly hematogenic chemotherapy and for acute chemotherapy-induced nausea and vomiting. So most of them recommended the 4-drug combination or 3-drug combination. And for delayed chemotherapy-induced nausea and vomiting, yeah, you can use a 3-drug combination. You have to drop 5-HT3 receptor antagonist. That's the point that I would like to make from these summary slides. And that was the study that I was talking about, that olanzapine was added to 3-drug combination. This study was published in New England Journal of Medicine like 5 years ago. And this study, the primary endpoint was to look at acute nausea and delayed nausea within 24 hours and from day 2 to day 5. And you can have a look at it. The patient, those who received 4-drug combination, there was a significant control of nausea, 74% versus 45% in patients who took 3-drug combination. So although you have given 4-drug combination, but still around 27 or 26% people suffer from delayed nausea, acute nausea. And then the delayed nausea is the complete perfect control, the comprehensive control was only 42%, despite the fact that olanzapine was added versus 25%. So 75 to 58 to 75% patients, they still suffer from delayed nausea. And that's why I was trying to make this point for delayed nausea is very significantly affecting the quality of life of patient. And that's why ASCO recommended 4-drug combinations. I would like to skip this slide just for the paucity of time. And this was the study actually when I was evaluating the formulary management at Ministry of National Guard Health Affairs like a couple of years ago. I found the netipitant in combination with palonosetron is as effective as aprepitant and granisetron combination, but netipitant has longer half-life, 7 days, so it covers the multiple days. Like for example, if it's a 7 days chemotherapy, the netipitant covers the 7 days chemotherapy, and I negotiated with the companies through the pharmacoeconomic department, and we made a deal, and netipitant palonosetron combination became cheaper than the apipitant and guanidinoate combination. They improved the compliance, reduces the pill burden, and covers the more complicated scenarios of the chemotherapy. And we approved netipitant in combination with palonosetron in our formulary, which is called Akenzio, or highly immunogenic chemotherapy. Now, let's move to the second part of my presentation, which is cancer pain syndrome. It's 8 o'clock, so we have an hour left, so I have to speed up a little bit. So the cancer pain syndrome, so, the cancer is really terrible. I talked about nausea, vomiting. Now, the pain is an obvious sign of cancer, particularly solid tumors. So it's seen in almost 1/4 to 1/3 of patients with newly diagnosed early stage solid tumors. And late stages metastatic disease, around 75% of patients they have severe pain. And these pain, they have different etiologies. This could be due to the nerve compression. This could be due to the mass. This could be due to the neuropathic pain component. This could be due to bone metastasis. This could be due to brain metastasis. This could be due to the fracture. This could be due to the inflammation. So that's where NCCN guideline is calling this cancer pain syndromes. Why? That we need to diagnose these syndromes. We need to understand the etiologies, and we treat the cause, and then we can treat the cancer pain. We cannot treat every cancer pain with opioids. We have to treat the cause. For example, if the bone is broken, then obviously you have to fix the bone fracture in order to control the pain. And if there is a cancer mass, which is compressing a nerve, then what you have to do, you have to treat this cancer with chemotherapy or with radiotherapy, or you have to do surgery and take it out, and that resolve the pain. But believe me or not, if you treat the cancer pain, you have done a great job. I remember one of our colleagues, senior pharmacist, she was diagnosed with breast cancer.
Dr. Mansoor?
Yeah.
Sorry to interrupt you, sir, but the slides are not moving, I guess.
Not moving?
Yes, sir. It is on the cancer pain syndromes.
Yeah, I'm just talking about the introduction. It's okay.
Okay. Sorry about it.
So one of my colleagues, she came to us in Shogat Khanam Cancer Hospital back in 2000 something, 2001, something like that. And there was no opioids in Shogat Khanam Cancer Hospital. She was advanced stage breast cancer, and she was dying from base. Actually, we had fentanyl patches before expired, like a day before, a couple of days ago. She came to me, and I told her that, we don't have this medication. We don't have, we have the fentanyl patches which are expired, so we cannot give it to you. She told me, I'm a pharmacist, so please give it to me. I'm sure it's working. So then I discussed with my director and other stakeholders, and then we agreed to give it to her. And believe me, she died within a month, but she was giving me a lot of duas and prayers that, I'm dying comfortably. Believe me, even if these patients are dying, if you can treat their pain, sit with them, talk to them, counsel them, treat their pain, treat their symptoms, and boost their morale, I can tell you that if you can control your pain, I can tell you that you have done a great job. So this is a 75-year-old man who has metastatic prostate cancer, who has very severe pain. Let me read this question a little bit faster. He has very severe pain. On the pain rating scale 8 out of 10, he's 8 out of 10. It's very subjective phenomena, but you can assess it. You can ask the patient to score it, and then it can tell you, and obviously you can feel it. Some people, those who are 8 out of 10 or 9 out of 10, they are not able to breathe. They're tachycardic. Some people are having tears. And the patient is taking oxycodone and acetaminophen, 5 milligram oxycodone, 2 tablets. And there's acetaminophen as well, 325 milligram in each tablet. Now this patient's pain is not controlled. So what we have to do, so option A, we increase the oxycodone acetaminophen dose. Can we do that? And option B, increase oxycodone acetaminophen dose to 10 tablets, 2 tablets every 4 hours. Option C, stop oxycodone acetaminophen and add morphine, sustained release every 12 hours. And option D, discontinue oxycodone acetaminophen and add morphine every 12 hours. Any answers? So C, Rehan Anjam is saying C. C is the right answer. Okay, so I think we talked about the goal of the cancer pain syndrome is to identify the syndrome and treat the cause. And if, of course, we have to make the patient pain-free at sleep, pain-free at activity. And if we have done that, I believe we have achieved our goal. And it's not only palliative care does not mean that is the terminal care. You know, some people, they have curable disease and they're having severe pain because it's just a mass compressing the nerve. So a patient will be treated with chemotherapy or radiotherapy or surgery. But during this point in time, she needs definitely good opioid, good pain management. And some people that think that the opioid, use of the opioid can cause addiction. So I can tell you that there is no addiction of opioid if it's a cancer pain. So there is no addiction whatsoever with the opioids if you're treating it for the right indication, which is cancer pain. So I was talking to you like cancer pain syndrome. So if this pain is due to inflammation, you can use ibuprofen, NSAIDs, corticosteroids. If the patient has bone metastasis, such as multiple myeloma, breast cancer, lung cancer, prostate cancer, you have to use bisphosphonate or Rankel inhibitor, which are the bone modifying agent, which reduces the activity of the osteoclast, improve the activity of the osteoblast, and improve the bone density. And if there's a fracture, of course, you have to do the surgery, fix it. And as I mentioned, like local bone pain, you might need chemotherapy or radiotherapy. And you have, of course, ask different specialties to send them referrals earlier in the treatment course, particularly the pain specialist should be referred if there's uncontrollable pain with opioids, with maximizing the opioids, orthopedics in case of the bone pain or fractures, and physiotherapy. Sometimes the physical medicine can play a big role in the management of the pain. So it's a subjective phenomenon to assess the pain. You can ask them to rate it from 0 to 10. And if it is 1 to 3, it is mild. And if it is 4 to 6, it is moderate. 7 to 10, it is severe. And there is a visual analog scale for children and those who are not communicating as well. WHO is using a ladder, 3-step ladder for mild to moderate pain. You use like acetaminophen. If it does not work, you move to weaker opioids such as tramadol or codeine. If it does not work, then you escalate to stronger opioids, morphine, stuff like that. So in this case, the patient is using oxycodone and acetaminophen every 4 hours, which is 6 times a day. So 5 plus 5, 10 milligram, 2 tablets, 10 milligram times 6, 60 milligram. And patient is taking nearly 4 grams of acetaminophen. So there is no way that you can increase this number of pills of oxycodone and acetaminophen. And the guideline says, in this case, what you have to do, you stop this oxycodone acetaminophen and give them longer active, long acting. You can titrate the requirement of the opioid and then switch them to longer acting opioids. So you can give them morphine or hydromorphone, etc. So discontinue oxycodone, acetaminophen, and add morphine every 12 hours. So that's the right answer. Of course, C is not a good option because you have to keep the ibuprofen. Now, this patient has shooting pain. Shooting pain is a symbol of peripheral neuropathy. So what do you think for peripheral neuropathy? What is the best option? Naproxen, single agent, acetaminophen, gabapentin, baclofen. C is the correct answer. Because naproxen, patient is already on ibuprofen. Acetaminophen, patient has already been taking it, doesn't gonna work. There is no muscle spasm, so no baclofen, so gabapentin is the correct option. So for shooting pain or peripheral neuropathy, you have the option to choose antidepressant, amitriptyline, anticonvulsant, topical agents. Methadone is very good. Methadone is opioid as well as NMDA receptor antagonist, so it works beautifully for peripheral neuropathy. or neuropathic pain. So these are the different agents that you can use: tricyclic antidepressant, as there's amitriptyline, nortriptyline, desipramine, duloxetine, and venlafaxine. Venlafaxine we have been using a lot, SNRI, for neuropathic pain, and pregabalin is quite commonly used. I typically start with 75 milligram every 12 hours. You can escalate it faster. And gabapentin, you have to escalate slowly. So the option is gabapentin. Now let's move to the next. We still have around 50 minutes and 60 slides to cover, so we're gonna go a little bit faster. So now let's go to the colony-stimulating factors in neutropenia and febrile neutropenia. We have NCCN guidelines, IDS ASCO guidelines. So how do you calculate absolute neutrophil count? So you know ANC, when you go to the hematology ward, on oncology ward, people use one of the acronym called ANC. ANC is absolute neutrophil count. So normally when we do complete that count, so we look at the WBC. So in this patient, WBC is 600 only. If you look at the way most of the labs are writing it, so they might have written it 0.6 times 10 raised to power 3. So then how do you calculate the absolute neutrophil count? This can be asked in the exam question, but most of the labs right now, they are calculating it by machine and reporting it directly, absolute neutrophil count. But for the examination purpose, you have to remember that segmented cell, you have to see the segmented cell, how many segmented neutrophil cell that you have and how many bands neutrophil that you have. And then you add them up, okay? So the total WBC is 600. How much is the 60% of 600? And how much is the 10% of 600? You have to add them up, and then that will be the right answer. So 70%, 60% plus 10% is 70%. So 70% of 600 will be the right answer. So is this 600 to 60 to 40 to 420? So I think I talked about it. So the right answer is 420. So you take 60% plus 10%, 70%. So 70% of 600 is 420. So the right answer is D. Okay, so given this absolute neutrophil count, which statement is the most appropriate? So now I'll tell you, neutrophils are the first line of defense. And those people who are immunocompetent, the reason they're not having any infection is the reason is that they have their first line of defense is active. So first line of defense, any organism, any antigen, any toxic substance which comes in our body is faced by the frontline soldiers in our body, which is constituting the frontline soldiers of our immune system, and that's neutrophils. So absolute neutrophil count is normally more than 2,000. If it is less than 2,000, more than 1,500 is called grade 1 neutropenia. Less than 1,500 to 1,000, grade 2 neutropenia. Less than 1,000 to more than 500 is grade 3 neutropenia. Less than 500 is grade 4 neutropenia. Grade 4 neutropenia is the one of the condition in which patient is at significant risk of catching infection. So these are the patients who need appropriate care and then should not go to the public areas or crowded areas because they can catch infection from anywhere. So there are many chemotherapies which can cause severe neutropenia or febrile neutropenia. We'll talk about that in a minute. So it is recommended that these patients who has severe neutropenia, febrile neutropenia, more than 20% of cases, we should give them colony-stimulating factor we call granulocyte colony-stimulating factor to prevent the neutropenia or to minimize the duration of the grade 4 neutropenia. So this patient is less than 500. So this is grade 4 neutropenia. So this patient is at significant risk of developing infections, febrile neutropenia, sepsis. Okay, so given this ANC, which statement is the most appropriate? Patient should be initiated on a CSF, or patient should begin prophylactic treatment, antibiotics, etc. Or patient who is neutropenic should be monitored closely for signs and symptoms of infection, or decrease the dose of AC with the next cycle of treatment. So who's answering this? A? No, A is not the right answer. Who says C? Asset. C. Rehan. That's correct. We'll come to it. So these are the options that you can choose. You have GCSF, granulocyte colony stimulating factors. So we have filgrastim. Now there's a talk about biosimilar filgrastim. Everybody talks about biosimilar filgrastim, which is the long-acting filgrastim. So we are using biosimilar filgrastim in our hospital for the last 6-7 years. So we have saved billions and billions of dollars by switching from the innovators to the biosimilars. Even in the United States, since 2015, people are using biosimilar filgrastim. And we have done a couple of studies as well on biosimilar filgrastim. So filgrastim, which is Neupogen, and biosimilar filgrastim, there are many of them. They are equally good. So give 5 micrograms per kg daily. And a paclitaxel, which I don't like, actually I would not like to recommend in my patient, but it can be asked in the examination questions. So you can give 1 dose, single dose, 6 milligram fixed dose strategy. But the thing is that the way it gets excreted from the body, it proliferate the granulocytes. When the neutrophils, there is a spike of the neutrophils, like neutrophils more than 40,000, 50,000, then it is excreted by the endothelial system cells. So these neutrophil spike will phagocytize and engulf the amount of the filgrastim which is in the body. So the spike of the neutrophils will actually lower the filgrastim concentration in the body, and followed by prolonged neutropenia, prevalent neutropenia. That's what I have observed in my patients and some patients. And for that reason, I deleted paclitaxel in the formulary of National Guard Health Affairs in Saudi Arabia. And then you have granulocyte macrophage colony stimulating factors, sargramostim, molgramostim. It's not only granulocyte colony stimulating factor, but also monocyte. You know, the granulocyte neutrophils are macrophages. They can phagocytize bacteria, but the macrophages, which is monocyte, once they are activated, they are second line of defense. They can phagocytize like 10 times more than what neutrophils can do. But in practice, people are not using GM-CSF anymore. Most commonly, we're using filgrastim or biosimilar filgrastim or paclitaxel. So indication, the exam question which can be asked the BPS exam, what is the indication of the filgrastim? So the FDA, US FDA, NCCN guidelines and ASCO guidelines have approved the use of filgrastim for primary prophylaxis in patients who are receiving a chemotherapy protocol, which is known to cause febrile neutropenia, in 20% of patients or more than 20% of patients. So this is examination question which people can ask you in the exam. You can definitely reduce the duration of neutropenia. You can treat it for febrile neutropenia as well, but it's not FDA approved indication. It's not an NCCN listed indication. However, it shortens the length of the hospital stay and duration of the antibiotics. And I did a pharmacoeconomic evaluation, and I found that when we use it for febrile neutropenia, it is cost effective, especially when you use biosimilar. But those dense regimens, so for example, AC, adriamycin cyclophosphamide, when you use it for breast cancer, we use it every 3 weeks. Studies have shown if you use it every 2 weeks, you can have better outcomes. But using every 2 weeks is known to cause significant febrile neutropenia. So then you need to give filgrastim along with it. So this is the NCCN guidelines. So you use filgrastim when chemotherapy is known to cause febrile neutropenia in more than 20% patients. And some patients who have the incidence of febrile neutropenia in 10 or 20% of cases, but their age is more than 65 years, at a high risk for developing infections. So you can also use it for those patients, but not for those patients who are less than 10%. So this is the list of the chemotherapy regimens for different diseases where the filgrastim should be used for primary prophylaxis. So there was a study published a long time ago, like 20 years ago, which had shown, this is the latest evidence for the use of filgrastim for the febrile neutropenia, which is 20 years ago, which had shown that there's no survival advantage by using filgrastim. And at that point in time, filgrastim was quite expensive. And for that reason, it was not recommended to be added to the febrile neutropenia regimen as an adjunctive therapy along with antibiotics. But it reduces the grade 4 neutropenia from by 2 to 3 days. an antibiotic regimen, antibiotic therapy duration by 1 day and hospital stay by 2 days. No survival benefit, but if you calculate these values, hospital stay, how much it costs you, antibiotic therapy, how much it costs you. So actually it's cost effective strategy to use it. But for examination purpose, it is not recommended. So if there is a question, option of using filgrastim for febrile neutropenia, your answer should be no, based on no survival benefits. Okay, so GCSF is generally used to prevent neutropenia and, of course, febrile neutropenia. And when we give chemotherapy, the neutrophil's half-life is about 1 to 3 days. After 4 to 5 half-life, we're expecting the patient to be neutropenic. We're talking about 7 to 10 days. So many people ask this question, when to start filgrastim. So you should not start on that same day of chemotherapy, because if you proliferate the bone marrow, the chemotherapy or cell cycle specific agents, they're gonna hit the bone marrow more harder and make prolonged neutropenia. Instead of that, if you can space like 24 hours from chemotherapy, and then you can continue for 7 to 10 days, that's okay. But the nadir means the time when there's a maximum possible drop in the count is 10 to 14 days. So some people actually, they start filgrastim from the day 5 or day 6 of chemotherapy, and they continue for 10 days. And that's a reasonable approach as well. And now we have biosimilar filgrastim, which is much more cheaper. Even if you use it for 7 to 10 days, that should be reasonable. You have to use it for curative therapy because you want to maintain the dose density. The density means you would like to use it same interval. You're not delaying chemotherapy, and dose intensity. That means you're maintaining the 100% of the dose, and that is associated with the overall outcomes in the patients. So you, instead of reducing the dose for the curative therapy outcome, curative therapy intent, you should use filgrastim to prevent as a primary or secondary prophylaxis. Primary prophylaxis, you know the protocol is dose dense, and you know the protocol is really toxic, so you use it. And the secondary prophylaxis is where actually you think you have seen the patient develop febrile neutropenia, and now you would like to prevent it in subsequent chemotherapy. So that's called secondary prophylaxis. And the patient, for example, metastatic prostate cancer disease developing febrile neutropenia, no need to give filgrastim, just reduce the dose of chemotherapy because your goal is palliation. So given this A and C, which statement is the most appropriate? Answer is C. The patient in neutropenic should be monitored closely for signs and symptoms of infection. There is no recommendation to give this patient CSF at this point in time because patients have not developed the febrile neutropenia before, and it's not known like what was the regimen. Now, we discussed it. Now we'll move to the febrile neutropenia. I will quickly discuss it. What is the definition of febrile neutropenia? We'll come back to this question. So after giving chemotherapy, chemotherapy, of course, kills the cancer cell, but it affects the bone marrow as well as rapidly proliferating cell lines, which is GI and mucosa as well. So we see mucositis, we see the bone marrow suppression, we see the neutropenia. So when there is significant neutropenia, grade 4 neutropenia, less than 500, and the patient can catch infection, particularly when the mucosal barriers are broken, the keratinocyte of the oral cavity, they are rapidly proliferating cell lines similar to the bone marrow stem cells, and when they are affected, and the patient has mucositis, and then this mucosal barrier is broken, then organism bacteria can actually leak into the bloodstream and cause bloodstream infections. And most of these patients also have the central line, so the bacteria can also leak through the central lines into the bloodstream, causing bacteremia. Febrile neutropenia is one of the very severe medical oncology or oncology or pathology emergency. Like MI is the emergency in cardiology. Febrile neutropenia is the similar kind of emergency in oncology. If you do not treat the patient in a timely fashion, you can lose the patient within hours. And it definitely eats the healthcare resources, affect the morbidity, mortality. It can affect the dose density and dose intensity, compliance, and compromise the efficacy of the treatment. And This is the definition. So you have to have the two criteria for the definition. There should be fever more than 38.3 degrees centigrade or equal to 38.3 once only, one reading only. Our patient is continuously febrile, 38 and above for 1 hour. And then the neutrophil counts, absolute neutrophil counts, will be less than 500. Or sometimes they ask you a tricky question, but I'm not sure whether they can ask BCPS, but they can ask, definitely they can ask you BCOP exam. That sometime I was talking about the data. Like for example, today patient is coming to ER emergency room with the previous history of chemotherapy, like 9 days ago, R-CHOP chemotherapy, and patient is coming with fever of 39 degrees centigrade and neutrophil counts of 800, which is more than 500, is grade 2 neutropenia. But are we expecting this patient to recover over the next 2 days? We are not expecting this patient to recover because the nadir period is 10 to 14 days. So the same patient, when he's coming day 15 or day 16, we are expecting this patient to recover. But on day 9 and day 10, we are not expecting this patient to recover. So this patient is included in the definition of the febrile neutropenia. So it's your assessment. Don't consider this is only physician who are responsible for assessing the patient. You are responsible for writing the guidelines. You are sitting in multidisciplinary meetings and you sit with physicians, you sit with the resident, you teach them. In my hospital, I'm the one who actually wrote the febrile neutropenia guideline and set all the criteria for evaluation of the patients. And we have to do the evaluation very quickly, and we have to start the antibiotics within 30 to 60 minutes of arrival in the hospital, because there was one study which had shown if you use antibiotics early, you can save. Actually, the start of antibiotics early is the difference between the death or significant morbidity and the survival of patients. So based on the criteria of the febrile neutropenia that we went through, somebody is writing in the chat box, D. Yeah, D is the correct answer. Thank you, Essen. Thank you, Noreen and Azim also. Thank you. Yeah, so D is the correct option. Dr. Noreen is the one who is board certified working in UAE. Are you the same? If you are the same, then I'm not surprised, but most of the other people are also giving me the correct answer, which is really great. Oh, thank you, Dr. Nori. Okay. So initial evaluation, we have to take the history carefully and do the physical examination and look at the patient comorbid illness, check the kidney function, chemistry, LFTs, and take 2 sets of blood culture. Because 1 set of blood culture could be contaminant. So taking 2 sets of blood culture, if the patient has central line and purple line, take 1 from the central line, 1 from the purple line. If the patient does not have the central line, you can take 2 from the 2 different anatomic sides, the purple line. And I'm not doing the physical exam myself, but I'm asking my residents, my physicians, my fellows, to do the exam carefully, like scan the patient from head till toe within seconds. Like for example, patient is coughing, ask for the chest x-ray. The patient is having abdominal pain and burning micturition, ask for the urine culture as well, beside doing the blood culture. If the patient is having loose motions and diarrhea, then ask for these stool studies as well. But do not do the rectal exam, because patient is neutropenic, and that area has a lot of organisms as a normal flora, and you can infiltrate many organisms during the rectal exam. And also patient might be thrombocytopenic, and they can have bleeding as well. And then when you have taken all the cultures, all the investigation, do not wait for the results to come out. You just have to start the antibiotics as soon as possible. Okay, I think I mentioned it already. So one of the study, largest series of studies, like more than 2,000 patients, was a prospective observational study, and had shown that around 1/4 of patients, 25% of patients, they have bacteremia. Around 75% of patients, they do not have bacteremia, but they may have a bacteria somewhere hidden, or they may not have any bacteremia or any infection. Because when you give chemotherapy, and chemotherapy hits the bone marrow harder, and the patient has mucositis and cytopenias. So there are a lot of cytokines also released. These cytokines can give you a spike of fever and patient is neutropenic, but you cannot take a risk. So you must have to treat with empirical antibiotics as soon as possible. So the most commonest organisms are gram-positive organisms, according to this study, 57% versus gram-negative at 34% and 9% were polymicrobial. But the gram-negative organisms were associated with more significant mortality and morbidity, 18% versus 5%. And whenever you are treating febrile neutropenia, the hallmark of the febrile neutropenia, the target that you're treating is Pseudomonas, of course. So all antibiotics that you're using empirically should cover Pseudomonas aeruginosa, except one option when you are treating low-risk febrile neutropenia with oral agent, you can use moxifloxacin for those patients as well, which does not cover Pseudomonas. So the reason is that these patients are not that much sick. We published one study, one of my residents in one of these Swedish paper, and just I want to show you that we found 19% isolates in our series of 100 febrile neutropenic patients. So 19 patients, they had bacterial isolates found. So which is going with the same study which I discussed before, that around 20 to 25% patients have like documented infections. So you have gram-negative organisms. So typically gram-negative rods, E. coli, Klebsiella, Enterobacter. Most of these organisms are normal GI flora. So what happens when there is severe mucositis from the oral cavity to the entire alimentary tract? So the organisms can leak into the bloodstream, causing bacteremia. So that's the most commonest source of infection. And the other is the central line. But your hallmark, your target for empirical therapy is Pseudomonas aeruginosa. We have gram-positive organisms. The most commonest organism that we have seen in the studies, in our study as well, as coagulase-negative Staph aureus. And most of the time it is contaminant, but in case of febrile neutropenia, you always have to believe it and you have to treat it. And the horrible organism here is also viridine group, streptococci, which is not covered by ceftazidime. So if you're using ceftazidime as a monotherapy, you have to add vancomycin to cover these organisms. Then you have C. diff, you have down the road after 4 or 5 days, if the patient is severely cytopenic, still mainly a hematology patient, bone marrow transplant patient, they can have fungal infections, such as yeast or mold infection, Candida or Aspergillus as well. So the general principle, you have to immediately treat. You don't have to wait for the results to come out. So start the empirical therapy as soon as possible. One of the QPI in our hospital was 60 minutes when I wrote the febrile neutropenia guidelines. So I recommended 60 minutes is the administration time. Since the patient arrived in the hospital, we achieved that 100%, thanks to our pharmacy, our nursing colleagues, our physician colleagues. Then I recommended to go a little bit more harsh with the nurses and pharmacy, and I suggested to have 30 minutes. There are studies which have shown that if you administer within 60 minutes of arrival in the hospital, you can reduce the mortality and morbidity very significantly, and you can reduce the healthcare resources, just ICU admissions and stuff like that, very significantly. And 30 minutes is working well, like in up to 80% of cases. We are able to administer antibiotics within 30 minutes. And for that, you can have ward stock antibiotics in ER and the floor where the patient actually can directly come to there. Okay, talk about it. So when you're assessing the patient, so the MASC guidelines, Multinational Association of Supportive Care in Oncology, I attended one of the meeting in New York, like in 2012, they presented 30 years data of using the MASC scoring system. So if the MASC scoring system does, it's an algorithm. Actually, I don't want to go through the details, but if you are interested, I can share with you the details later on. So the MASC score is less than 21, that's high risk. If the MASC score is more than 21, that's low risk. So what they did basically, the high risk patient, they had admitted them in the hospital for IV antibiotics, and low risk patient, they gave them 1 shot of IV antibiotics and then gave them the oral antibiotics. Around 90% of the patient did not come back to the hospital with oral antibiotics when they were given oral antibiotics after IV shot in the ER. and which definitely saves the healthcare resources, but that's not possible in countries like Pakistan, UAE, and Saudi Arabia, where we don't have uh, the bed assurance for the patient. If the patient comes back and there's a bed crisis and there's no way to admit the patient. So what we do basically, we categorize all patients in high risk categories and we admit them. So for a low risk patient, there's two options. You can use ciprofloxacin in combination with augmentin, and I always prefer this regimen, 1 gram BID, because you give less glycolate acid, only 250 milligrams per day, less diarrhea. And ciprofloxacin dose is 750 milligrams control. Or you can use oral moxifloxacin, and many people can question that it does not cover the Pseudomonas. The reason is that the patient is low risk. That's why there's no need for anti-Pseudomonas coverage in this patient. For high-risk IDSA, Infectious Disease Society of America, and NCCN guidelines and ASCO guidelines, they recommend either to choose cefepime or imipenem, cilastatin, meropenem, or piperacillin, tazobactam. Ceftazidime had been dropped actually from the category 1 or A1 recommendations for many reasons. It has issues of auto-induction of beta-lactamases, and it does not cover the streptopyridine, stuff like that. But now that's addressed by newer combination of ceftazidime plus avibactam, but that's reserved for KPCs and CREs, most resistant bugs. That's not recommended for empirical administration of antibiotics in fibrotic patients. So this is NCCN guideline, very similar to that. But you have to use anti-pseudomonal dose of all these things. So you have a look at it, ceftazidime is category 2B, not category 1. So others are category 1. The questions which can be asked in the exam is category 1. So you use monotherapy in most instances, but sometimes in your hospital, depending on your antibiogram, for example, in our hospital, we have around 30% ESPO. So we recommended to add tazocin, amikacin in combination with tazocin as our empirical antibiotic regimen. So if you have more, for example, ESBLs, you can even start with carbapenem frontline, but there are some other drawbacks of using carbapenem upfront. You will have more you will develop more resistant organisms such as KPC, CREs, and steatotrophs, etc. And patients also have penicillin allergy. You can use ciprofloxacin plus clindamycin combination. So cipro will cover the gram-negatives, clindamycin will cover the gram-positives. Or you can choose Estrinam plus vancomycin for high risk. Estrinam covers only gram-negative, and vancomycin covers only gram-positive. When to add vancomycin? I think we have around 22 minutes still, so I think we have like 20 slides more to go over. So there are 6 indications where we can add vancomycin or gram-positive coverage upfront from the day 1. The patient is hemodynamically unstable, like patient has signs of sepsis, hypertension. Patient has documented radiographically pneumonia. Patient was coughing, you did the X-ray, you found out pneumonia on the day 1, so you can start vancomycin. The patient has a positive blood culture for the gram-positive bacteria because the gram stain can come on the same day. And if there is suspected catheter-related infection, the patient has skin and soft tissue infection, or patient has colonization of MRSA, VRE, etc., or patient has grade 3 to 4 mucositis, because in grade 3 to 4 mucositis, what you can have, the Streptococcus and Streptococcus in oral cavity can leak into the bloodstream, causing the bacteremia. So for those patients, you definitely need gram-positive coverage. And how do you modify the regimen over the next 24 to 48 hours? If you find out MRSA, you can add vancomycin, linezolid, or streptomycin. In case of VRE, you can add linezolid, streptomycin. If extended spectrum beta-lactamases is isolated, then you switch tazocin plus amikacin to carbapenem, like imipenem or piropenem, whichever agent is available in your institution and whichever is more cost-effective. In case of Klebsiella pneumonia, carbapeminase or CREs, I was talking about avicase, which is ceftazidime avibactam can be used. And for C. diff, you can add vancomycin or fidaxomicin. So this is the summary of what we have discussed. Low risk you treat with oral agents, and high risk you have to admit them. they have anticipated profound neutropenia more than 7 days. You treat them with IV antibiotics, and you see if there's any criteria for adding gram-positive agents, antibiotics. You can add vancomycin, linezolid, etc. So this is the summary of what we discussed. And this is how you are going to monitor them over the next 2 to 4 days. So mainly focusing on high-risk patients. If they have documented infection, so many people, they ask like how long we have to treat. So we have to treat the patient for the, for example, if this is gram-negative organism, you have to treat it for 10 to 14 days. If gram-positive, you have to treat it for 14 days. But if the neutrophils have not yet recovered, like neutrophils are less than 500, you have to continue empirical antibiotics until the neutrophils are at least more than 500 postnatal. So in case of induction chemotherapy in AML, ALL, sometimes people are not recovering up until 3 weeks or 4 weeks. So many people have been asking this question. So there is no answer from the guideline, but from the clinical practice, if there is some evidence of recovery of the bone marrow, you can de-escalate antibiotics. But for the examination purpose, the answer is that you have to continue antibiotics until ANC is more than 500. If there is a patient still having fever, not yet differ-beast, and culture, patient is differ-beast, but culture is negative, you still have to continue antibiotics until ANC is more than 500. But if the patient is still not differ-beast, still having fever, but clinically stable, you continue just the same antibiotics. But if the patient is having persistent fever and clinically not stable, not responding, you definitely do the culture for each spike, and you can continue doing the CT MRI. For example, if there's any chest symptom, do CT chest abdomen pelvis to see any collection, any pneumonia, any pulmonary nodules, depending on the host status characteristics. For example, if it is ALL patient post-transplant, so there is a risk after 4 days the patient can have pulmonary nodules, which is aspergillosis, and you can do also some molecular studies. There's serum glutamine and stuff like that, and which can help you in deciding whether we need to give antifungal and which type of antifungal we can use. So typically, fungal infection does not occur in first 4 days, but after 4 days, this is a perfect host. When duration of neutropenia, for neutropenia is more than 4 days, this is a perfect host for the yeast, particularly to grow. And if this is a profound neutropenia, which is neutrophil count less than 100, this is a perfect condition for the molds, as Aspergillus and mucormycosis, to grow. So in that case, again, you have to do the radiographs, just radiograph, not this X-ray. You have to do the CT scan and biological laboratory markers, which is galactomannan, particularly, which is an indicator of the mold infection. This is present in the cell wall of the Aspergillus. It can help you decide what type of antifungal we can use. For example, if there's a pulmonary nodules, and there is a galactomannan positive, serum galactomannan positive, which is less sensitive but more specific. If it is positive, it really tells you this is invasive aspergillosis. You have to treat it with more sort of anti-mold coverages, voriconazole, etc. So this is what I was talking about. This is a summary of that. You can take it from Dr. Rida, my slides, and go over it. And for the examination purpose, you can, these are the listed options in Infectious Disease Society of America. Empirical therapy, you can choose fluconazole, but examiner will be always asking about the kind of candidate. This caspofungin is the one which is approved for febrile neutropenia. It covers Candida and it covers mold. If there is an option to choose amphotericin B products, as Embizome or Ebelset, that will not be the wrong option, but that's not also correct option because of the toxicity. So the caspofungin is the most safer and effective. However, if you have some sort of clear picture like pulmonary nodules on CT scan or galactomannan is positive, then you can use preemptively voriconazole. Now, consideration of anemia. One of the studies, one of the survey conducted in US a long time ago, at the time when I was actually getting my training in Shogakukan Cancer Hospital, had shown that one of the most commonest symptoms that patients are suffering is fatigue, not nausea, vomiting, not fear loss, not alopecia, not anything else, was fatigue. Fatigue is very bothersome. They cannot do the normal activities. And there are many causes of any fatigue, but one of the commonest cause is anemia. And that really happens down the road after 3 to 4 cycles. Half-life of hemoglobin is about, RBC is about 90 to 120 days. So you don't see a direct effect on bone marrow or anemia from chemotherapy, but there might be some other factors, as patient is not eating well, stuff like that, and the patient might have like, or maybe bone marrow is involved, so they can have anemia earlier on. So these are the options. We can come back. So if the patient has anemia and they have a feeling of tiredness, they have fatigue, then we can treat this fatigue and anemia with 2 treatment options. Either we can use erythropoietin stimulating agents, or we can give them blood, which is packed RBCs. Now, the thing is that NCCN guideline back in 2006-7 has updated that, recommended since that time, do not use erythropoietin stimulating agents for cancer patient who has curable disease, because use of erythropoietin stimulating agent was associated with shortening of overall survival. So in those patients, for example, ALL patient, lymphoma patient, early stage breast cancer, early stage colon cancer, if they have anemia and significant anemia, less than 8, really, we do not transfuse RBCs if the hemoglobin is 8. Even some people, they go up to 7. So less than 7 or less than 8, we have to give it, because it's not only it's not only fatigue which is resulting from this anemia. It's also grade 4 anemia can have multi-organ failure, such as heart failure. Actually, if you are a BCOP candidate, then you have to know the gradings, CTC gradings for anemia, for thrombocytopenia, all the complications. For erythropoietin stimulating agents, the perfect candidate are those patients who have hemoglobin of less than 10 and they have incurable disease, which is grade 4, stage 4 disease or advanced disease, but not curable disease. Okay, so you should not use it for a curable disease. So this is 45-year-old woman who's beginning her 3rd cycle of adjuvant treatment of breast cancer. A diagnosis hemoglobin was 10. Today it is less than 10. The patient has fatigue that is interfering with her activities of daily living. Adjuvant means early stage breast cancer. That means it's curable. Patient has fatigue that is interfering with her activities of daily living. Which is the most appropriate treatment option? Treatment with erythropoietin should be considered. Treatment with darbepoetin, or patient is being treated in the curative setting and therefore is not eligible to receive an ESA, or D. So what is the best option? So people are writing C, very good. Yeah, C, because this is curative setting, it's adjuvant treatment of breast cancer. That means early stage breast cancer. So it is not recommended to use ESA. Okay, now dexrazoxane, I think you guys are familiar with it. I never see dexrazoxane. I always hear about it, always read about it. I've seen only once in my life, in my more than 20 years career, I've seen it only once. It's basically antidote for anthracycline, which can cause cardiotoxicity. The mechanism where how the anthracycline causes cardiotoxicity is the production of the free radical called superoxide. So our body has ample amount of superoxide dismutase, which dispose of this dangerous free radicals from the body. But our heart, unfortunately, does not have superoxide dismutase. So it's not able to dispose of superoxide from the heart. And also, fortunately, our tumor in our patient does not have superoxide dismutase, which is good. So anthracycline kills those cancer cells. But myocytes, which is the heart cells, are affected and killed by not having superoxide dismutase in the heart. So for that reason, dexrazoxane can be used. It is actually similar to iron chelators. So it scavenges those free radicals, and it is FDA labeled indication is those patients who have received doxorubicin 300 milligram per meter square or equivalent dose, and patient is still responding to etracycline, and they still need to continue doxorubicin or etracycline. So these are the patients who actually can benefit from addition of dexrazoxane. But it has its own hematological toxicity as well, and also there was a concern in the earlier studies. Those patients who received dexrazoxane, they had lesser outcomes. So we have 38-year-old woman who has a history of Hodgkin lymphoma. 2 years ago, she completed 6 cycles of ABVD. So one cycle of ABVD is 25 plus 25, 50 milligram per meter square. So 6 cycles mean the patient has received 300 milligram per meter square. And the patient needs treatment again. And what is the best option? So if we give enterocycline again, can we give this patient dexrazoxane? A, B, C, or D? Anybody in the chat box? The patient has reached the appropriate cumulative dose of doxorubicin to consider dexrazoxane. Perfect. Perfect. Okay, now the consideration for the mesna, which is mercaptoethane sulfonate sodium. It's also one of the chemoprotectant, and ASCO guideline has recommended to use mesna with any dose of ifosfamide, and cyclophosphamide. They are metabolized to phosphoramide mustard, which is used as anti-cancer activagen, and acrolein. Acrolein is a toxic metabolite which binds with the bladder wall that produces hemorrhagic cystitis. And mesna prevent the attachment of the acrolein with the bladder walls and prevent the hemorrhagic cystitis. And that's how we use mesna. For short infusion, like when we give ifosfamide over half an hour to 1 hour, we give 3 doses of mesna, 20% each dose, 20% of ifosfamide dose. For example, ifosfamide dose is 1 gram, 1,000 milligram per meter square. So we have to use 200 milligram per meter square along with ifosfamide at time 0, then at 4 hours and 8 hours. I'm not talking about oral agent, that's more complicated. And when we're using continuous infusion, we use 20% at time 0, then 40% along with it, and continue 12 to 24 hours after, because the half-life of mesna is shorter and ifosfamide is longer. This is the guideline that we wrote for our hospital here, just a screenshot of that. And this is based on the ASCO 2008 guidelines. So which one of the following is the correct sequence for administering mesna and ifosfamide? Mesna before ifosfamide, and then at 4-8 hours after mesna, or 4-8 hours. So let me tell you, okay. Correct option is A. Thank you, Dr. Pusher. She said the right answer. Okay, because for short boluses, we give at 0 times 0, 4 and 8 hours. And if we have to give oral, then we give IV at 0 hours, oral double the dose and give it at 2 hours and then 6 hours. The last is the tumor lysis syndrome. Tumor lysis syndrome is a metabolic complication after the tumor cells break down. And sometimes it happens even before the start of chemotherapy. So our immune system is killing the tumor cells, and then the tumor cell content leaks out. So we have potassium in the intracellular content. We have phosphorus, so there is hyperkalemia, hyperphosphatemia. Whenever there is hyperphosphatemia, there is hypocalcemia. And when the DNA breaks down, it results in hyperuricemia. And then hyperuricemia can cause renal failure. Hypokalemia can affect the heart. Hyperphosphatemia can cause hypocalcemia, that can cause metabolic acidosis, heart failure, arrhythmias. So this is sequelae, very complicated sequelae of the tumor lysis syndrome, metabolic complication. And we have to assess the patient earlier on. So this is the risk stratification. High-risk patients are Burkitt lymphoma, ALL patient with the WBC count more than 100,000, AML patient with more than 50,000. So these are the patients who should receive ample amount of tumor lysis syndrome prophylaxis. We have to treat hyperuricemia, of course, with allopurinol. Respiratory care, we're going to talk about that in a minute. Hyperkalemia, you have to treat as you are treating in a non-cancer patient. Hyperphosphatemia, you have to use it, treat it with the phosphate binders, but give the phosphate binders along with food. Do not give it on empty stomach. And hypocalcemia, if they're not symptomatic, you don't treat them unless it is significantly low, like less than 1.75 millimole per liter. In that case, you just give modest amount of calcium, because calcium phosphorus can bind and can cause precipitation. And this is the ASCO guidelines and our institutional guidelines as well. So for high risk, you have to give aggressive hydration and maintain very good urine output, like 100 ml per hour, and initiate respiratory 6 milligram. FDA approved dose is 0.2 milligram per kg per day for 5 to 7 days, but even ASCO has recognized the 6 milligram single fixed dose strategy is as effective as multiple days, and it's cost effective. And we did a study that I share with you. And this is the prophylaxis. For the treatment, you have to definitely use, and at any point in time, you have the tumor lysis syndrome, you have to use respiratory case, you have to use aggressive hydration, consult nephrology. But in my experience, whenever we consulted nephrology, they have managed the patient poorly. So the best people who can manage the tumor lysis syndrome, in my opinion, with all respect to the nephrologist, is the oncologist, hematologist, oncology, hematology clinical pharmacist. Urinary utilization is not recommended, and they always do that. There's a significant disadvantage of that. You have to monitor this patient more frequently, every 12 hours or every 8 hours. This slide talks about the differences between the allopurinol and the respiratory case. Allopurinol is a xanthine oxidase inhibitor. It just prevents the formation of the uric acid, whereas the respiratory case is the enzyme which works on the preformed uric acid. But you have to be cautious in a patient who is G6B deficient, so you should not use respiratory case because it can cause severe hemolytic anemia. And it's very cheap, allopurinol, and respiratory case is very expensive. Allopurinol is very weak, and respiratory case is very strong anti-hyperuricemic drug. So we have this last question, audience response question number 11. ALL patient developed tumor lysis syndrome on day 2. So this is the lab parameters. Uric acid is 12 milligram, the deciliter is high, serum creatinine is 2.54. So there is a clinical tumor lysis and there is laboratory tumor lysis. Potassium is high, phosphate is high. So which one of the following should be started to manage his TLS? So Dr. Bushra and Dr. Noreen is saying A. Unfortunately, A is not the right option because uric acid is very high. So it's laboratory and tumor lysis syndrome. So allopurinol is okay for prevention, but for treatment, B is the correct option. So you have to give aggressive hydration and respiratory. Sometimes the BPS asks you a question tricky. They may give you aggressive hydration as an option, and they may give you the second option, respiratory case, so that they try to trick you out. So respiratory case will not be the correct option. Aggressive hydration is the correct option, and anything along with aggressive hydration in this patient, I consider respiratory case is the best option, because you have to maintain very good urine output. This is the hallmark of the TLS management. We published one of the paper in a very famous American Journal of Pathology Oncology Pharmacy, using 6 milligram fixed dose strategy, and in around 100 patients. And most of the patients they present with spontaneous tumor lysis syndrome. And our primary endpoint was to use 6 milligram fixed dose strategy and to see like normalization of uric acid at 24 and 48 hours. And around 80% of patients they had normalization of uric acid at 24 and 48 hours. And the secondary endpoint was the normalization of uric acid at 96 hours. So 90% of patients had normalization of uric acid at 96 hours. Normalization of serum creatinine in 70% of patients at 96 hours, and patient requiring single dose were 80%. And then we'll try to look at who were the patient who required the second dose, and try to look at the correlations. So most of the patients who took the second dose or required the second 6 milligram fixed dose were actually those who had abnormal kidney function or who presented with renal impairment. And then we tried to also look at the appropriateness of the second additional dose. It was a retrospective study anyway. So And only 33% patients who required the second dose were actually the likely candidate for the second dose, and 67 two-thirds patients were actually not the candidate for the second dose, because in order to give the second dose, patient uric acid within 96 hours should jump and go above 7 milligrams per deciliter, which did not happen in two-thirds of patients who received the second dose. And this had significant cost saving benefit. Our direct cost, procurement cost was quite low, but we found like 1.2 million real saving. And this was published in Journal of Oncology Pharmacy a couple of years ago. With that, I would like to say thanks for your attention. And it was really nice discussion with you through the chat box. You have been answering questions. You will have very similar kind of inshallah, questions in the BPS exam. Yes, A was the previous question. Okay, Dr. Bushra is saying A was the previous. I'm sorry. A was okay. Dr. Noreen is also saying A was. So you have any question?
Participants, yes. If you have any questions, you may share in the chat box, please.
I can stay here, no problem at all.
I guess there is a question in the chat box.
Okay.
Okay, no. Sir, do we have any recommendations for phosphate binders based on levels?
Yeah, so you can use phosphate binders based on the levels. For example, if the phosphorus is really high, like more than 2 millimole per deciliter, multiply it with 3.1, so more than 6 or 6.5. So you can use phosphate binders. You can use anyone. I prefer to use something like aluminum hydroxide, which is called Amphogel, if it's available. But some people are concerned about its toxicity in the patient, those who have like renal impairment, but you don't have to use it for longer periods of time for aluminum toxicity. And my second best choice is Sevelamer. Sevelamer is a very good. Actually, you have to use it only for 4 or 5 days, not more than that. So somebody can argue like Sevelamer is expensive and as effective as calcium carbonate. My third option is calcium carbonate. But calcium carbonate, you have to make sure that you are using with food, not on an empty stomach, because otherwise this calcium will be absorbed and calcium phosphorus product will be high, more than 55, and that can result in, precipitation of calcium phosphorus chelates, and that result in nephrocalcinosis and soft tissue calcification, and that has some other disadvantages. So yes, you can use phosphate binders, but believe me, the aggressive hydration is the hallmark of the TLS management. If you do good urine, if you maintain good urine output, the phosphorus is not going to stay there. Only in case of Burkitt lymphoma are those tumors like ALL, leukemia, like hyperleukocytosis, who have huge turnover of the tumor cells. They might have like a significant hyperphosphatemia requiring Sevelamer or calcium carbonate or aluminum hydroxide. But in most of the patient, if you're maintaining good urine output, aggressive hydration, you don't have to really worry about hyperphosphatemia. But after 4 or 5 days, in some scenarios, if the phosphorus does not go down and potassium does not go down and uric acid is not controlled and kidney function is deteriorating, then of course you have to consult the nephrologist for the hemodialysis. And most of the time you do only 1 session of hemodialysis, not second session. Second session is not required, unless otherwise there's chronic kidney disease existing from before.
Okay, thank you so much, sir. Is there anyone who also have any question? Okay, so I guess the questions are over. Is there anyone? I'm asking again, who have any question?
If they don't have any question, then I have a question. Just, can I chat like a minute?
Yes, sir, of course.
Like, how many people have taken BCPS exam before? And did you see these kind of questions in the BCPS exam?
Sorry, sir.
How many people have taken the BCPS exam before? And have you seen these kind of questions? Yes, there are extra 2. Okay. Who is this Dr. Sidra Khan from UK? Okay, nice to know many people here. Okay. Okay. So there is more questions, because the thing is that we wanted to cover like important elements of the oncology supportive care. We did not cover. We covered only if you are oncology practitioner, Dr. Sidra and Dr. Bushra, those who are, and Dr. Noreen, those who are practicing in oncology, they know that we did not cover more than 1% of what we do in our clinical practice. And we need days, if not months, to cover oncology supportive care. It's an ocean of knowledge that we have to deliver. But I was under the impression that in BCPS, they probably will need less intensive sort of questions. So I was expecting, because I never took BCPS, so I was expecting that this content will be enough for them. So do you think this content is enough, or you have to read more?
Okay, so thank you so much, Dr. Mansoor, for your time and efforts. We really appreciate that you prepared that elaborative and informative presentation with us. And we hope that the participants will find this presentation really very beneficial in their preparation for the BCPS exams. So if you want to share anything else.
Yeah, it's
With our
fine. Thank you so much.
participants.
Thank you so much. Thank you so much. Thank you so much. Thank you, everyone. Wish you good luck for your success in your future career exam, BPS. Everybody who is in Pakistan, outside Pakistan, wish you good luck. And you can share my slides, Dr. Rita, with all the participants and whoever wants it. You can give them PDF, you can give them PowerPoint. I have no restrictions on that.
Okay, thank you so much, sir. And I would like to thank our participants at the end of the session for being with us throughout the session and given active participation. It's a reminder that we will have our next BCPS class on Saturday, 21st August with the topic of pediatrics with Dr. Sabah Javed. And till then, take care everyone and Allah Hafiz. Thank you for being with us. Thank you everyone. Allah Hafiz.
Allah.